My name is Peter Dietz. I'm Professor of Obstetrics and Gynecology with the University of Sydney in Sydney, Australia. With this video, I'm going to try and introduce you to the 4D View, which is a piece of proprietary software available through the Wawasan Club. I'm interested in this software because it massively simplifies the analysis of ultrasound volume data obtained on pelvic floor imaging. I've selected 7 de-identified volume data sets. The first is going to illustrate pelvic organ descent. The second one, assessment of the levator hiatus. There's 3 that focus on the tomographic imaging of the levator ana muscle, 1 with an intact muscle and 2 with different forms of avulsions. The last 2 data sets illustrate tomographic assessment of the anal sphincter, 1 for an anal sphincter that's normal and the other in a patient who's had an obstetric anal sphincter tear repaired in labor ward with a suboptimal result. I'm about to demonstrate the measurement of organ descent on Valsalva in a lady with a mild 3-compartment prolapse. On the left-hand side here, you see the standard mid-sagittal plane with the symphysis pubis in front, the urethra, the trigone, the bladder with the detrusor here, an anteverted uterus with the cervix here, the rectal ampulla and the anal canal. On the right-hand side is a semi-transparent representation of all the pixels in this box, and of course that box extends laterally. So we're going to get her to do a Valsalva here by letting the timeline run to the right. This looks like it is maximum Valsalva. We shift the box so that our line of reference here goes through the inferior margin of the symphysis pubis. We then measure the distance from that line to the bladder neck, which is about here, to the maximum extent of that cystocele, which is about here, to the cervix, which is here, and to the rectal ampulla, which is here. So what that means is that she's got a cystocele to 2.3 centimeters below, the uterus to 1.3 below, the rectal ampulla to 2 centimeters below. The next thing to check is whether she actually does have a true rectocele, whether there is a pocket of the rectum that extends into the vagina, and for that we need to see the internal anal sphincter, which is here, and you can see that there is a distinct pocket even if it is relatively small. The way we measure that is by running a line through the internal sphincter and then measuring vertical to that. So this is a rectocele that's 11 millimeters in depth. It's tiny. This does not really matter. The last thing to check is whether we truly have the cervix there. And the way to do that is by going through the volume using the reference slider. It looks like there's the Bothian follicle just visible here in the cervix, so that is the extent of it either to here or to there, which is a little hard to see in this particular volume. But there's most definitely there's that Bothian follicle again. There's definitely uterine descent to at least the level of the symphysis pubis, likely slightly below that. I'm going to demonstrate the determination of hiatal area on Valsalva in this lady with a mild 3-compartment prolapse. Here at rest in the mid-sagittal, you can see the symphysis pubis, the urethra, the bladder neck, the trigone, the bladder with the detrusor here, an anteverted normal-sized uterus with the cervix here, the rectal ampulla and the anal canal. Here in the back is the anorectal angle, that is the levator ani muscle. In the rendered axial volume, which we can modify like this, you see a semi-transparent representation of all pixels in this box, and of course it extends sideways, so that here in the axial plane there's the pubic rami left and right. Maybe I can show that a little better. Here, that's the pubic rami just meeting here in front where the symphysis pubis is. There's the urethra, there's the vagina, this is the vaginal lumen here, and there's the anorectum with the levator muscle on the outside. We're going to get her to perform a Valsalva maneuver, for which I use the timeline here at the bottom, and you can see that there's quite a bit of descent, in particular of the front wall of the vagina, which is happening here. The urethra is rotating quite a lot, so the urethra rotates through about 120 degrees. There's marked urethral kinking like so. There's the bladder neck, which comes down to at least 2 centimeters below the symphysis pubis. There's the cervix in this area here, and there's the rectum with a small rectus here. And what we really want to do right now is to measure the hiatus, the largest potential hernial portal in the human body. You can see that the contour is here is rather distinct. So the symphysis pubis in front, the pubic rami then across to here, around all the way. You want a box that's between 1 and 2 centimeters wide. Occasionally it has to be even deeper than that, and you can see by adjusting that I can make the contour show up a little better or less well, depending. You want to have the anorectal angle in this box, and you want to have the symphysis pubis in this box. We go to measure. The measurement package loads, and the speed of that will depend on your computer. You click generic area point, and then we run the area point cursor all round this contour. Gives us a heightal area of 35.45, which is a marked ballooning. I'm going to show you tomographic assessment of a normal puborectalis muscle. In this lady here who's got excellent pelvic organ support, she's just voided, the bladder's empty, the symphysis pubis is here, the urethra, the vagina, the anorectum, here the anal canal, the anorectal angle. On the left-hand side here you see the mid-sagittal plane, the A plane. On the right-hand side a rendered volume in the axial plane, that is a semi-transparent representation of all pixels that are in this box. And of course the box extends to the left and to the right. It's in 3 dimensions. In order to assess the levator, we want a pelvic floor contraction because that tends to improve tissue discrimination. So this is what we're simulating here with me running the timeline here. That's a pelvic floor contraction. In fact, she does also activate her abdominals, because while to about here, the effect is exclusively one of a reduction of the plane of minimal dimensions, of the minimal distance between the back of the symphysis pubis here and the front of the anorectal angle here. So this distance here has shortened with that contraction from here to there. But now something else is happening, and for those last few volumes here you can see that the bladder neck, all the pelvic organs actually move downwards a little. That implies she's co-activating. She's actually contracting her abdominals. Not that that makes any difference to the assessment of the levator. It's just something that you may consider talking to her about to reduce the likelihood of her doing a contraction that's confounded by contraction of the abdominal muscles. We then we find the plane of minimal dimensions and put that in the middle of this box of the region of interest. So the back of the symphysis pubis here, the front of the anorectal angle there. Once we've got that kind of appearance, we can go to TUI in the C plane. Then we rotate the C plane clockwise by 90 degrees to put it upright, so that now it is as if you're looking at the bottom from below. This is the patient's left side, this is her right side. The urethra there, the vagina there, the anorectum here. The next step is to make sure you've got the correct interslice interval of 2.5 millimeters, and then you need to adjust the symphysis pubis. There's the pubic rami here and there, and that's one of the many arcuate ligaments in the human body. You want this particular frame to show the symphysis pubis as just closing. And it's not that obvious here, but I think you saw the pubic rami meet here. So open in this slice, closing in that slice, and basically gone, invisible due to acoustic shadowing here in that slice. We can blow it up a little bit, although we do want to see the symphysis pubis in front and the anorectal angle in the back. You can see that's a rather substantial muscle. It doesn't really need any further improvement in appearances, but you can try and put VCI on, which usually makes things a little bit clearer. You can also go to image settings. Maybe it's a little bright, so you could go down with the read gain, like so. You can play with bias and with the position of the transition. This looks fine to me. What you do want to see, though, is the center of the urethra, and that's not quite so clear here. Let's see whether that helps at all. Bring the read gain up. Yeah, it does. You can just about pick the urethra up here. It's obvious that's obvious there. You need that in order to measure in order to measure the levator-urethra gap from the center of the urethra to muscle insertion, left and right. This is a very strong muscle. It's much thicker than average. It looks athletic, to say the least, and we're not surprised to see that all those measurements of the levator-urethra gap are well below the cutoff in Caucasians, which is 2.5 centimeters. Incidentally, further up, of course, the muscle is just as normal here. It's just that you do need those three slices, the three central slices, to determine the minimal criteria, that is, whether this is a full avulsion or not. It's obviously not. Incidentally, also, further up here, you can still see the sonolucent symphysis pubis here in the middle, the disc between the pubic rami, between the os pubis left and right, and this here is the acoustic shadow that you get from the pubic rami. Another issue, something else to point out, is the appearances in the coronal plane, and for that we go a little bit higher here. What you see here is a reference plane in the coronal plane, and there's a lot of muscle here and there, and it's quite symmetrical. You can see that this inverted funnel of the pelvic floor muscle opens up further, and that the muscle gets a lot thinner here in this area, which is the iliococcygeus. Higher up you can't see it at all. The same on the other side. What matters is there's a big bulky muscle here and there, which is represented in the insertions here and there and there and all the way through. So obviously this is a completely normal and rather athletic looking pelvic floor. Next, I'll demonstrate assessment of the puborectalis muscle by tomographic imaging in this lady who has a highly abnormal muscle and three-compartment prolapse. We start with the standard acquisition screen, that is the mid-sagittal plane here on the left, and a semi-transparent representation of everything in this box, which is called the region of interest, on the right-hand side. This is the axial plane. So you're looking at the bottom from below, the symphysis pubis in front, the pubic rami, the urethra, the vagina, the anal rectum, and here in the muscle. You can see that by shifting the location of the region of interest, you can change appearances quite markedly. And there's the symphysis pubis and the pubic rami now. But before we start on the TUI, we get the patient to do a pelvic floor contraction, because that tends to enhance tissue discrimination. Although it's not absolutely necessary to use a contraction for assessment of the puborectalis. Once that's happened, once we've selected a volume with a good contraction, we then would want the plane of minimal dimensions from the back of the symphysis pubis to the front of the anorectal angle in the middle of the box, because if that's the case, we can switch to TUI in the C-plane straight away. We then need to rotate the C-plane so that it's upright, just like what you saw before in the rendered volume in the axial plane. We can rock that volume a little to make it more symmetrical, so appearances are pretty much the same left and right. The interslice interval is correct at 2.5 millimeters. You can see the symphysis pubis, the pubic rami here and there, clearly open. It's closing there, and you can't see it anymore here because it's in acoustic shadow. We haven't quite rotated it straight. That's better. There are several ways to improve appearances, and the simplest is to use VCI, usually between 2 and 4 millimeters interslice or slice thickness, but you can see that it looks similar in all those different options. It's just that the thicker you go, the more likely you are to get artifact. So somewhere between 2 and 4, that looks pretty good to me. We can enlarge a little because all we really want to is to see the symphysis pubis here in the middle and the anorectal angle here. Can we optimize this a little more? There, that looks really clear and sharp now. So the pubic rami here and there's open, it's closing there and gone there. And a little bit more rotation. The one remaining step now is to demonstrate the levator-urethra gap. So from the center of the urethra to wherever you can see insertion of the muscle on both sides, and it's immediately apparent that there is a huge difference between right and left. The cutoff in Caucasians is 2.5 centimeters. You can see that all three measurements on the left-hand side are clearly normal. On the right-hand side, they are way above 2.5. So this is a full right-sided avulsion, and it is defined by the minimal criteria of at least the 3 central slices all being abnormal on one side. In this lady, clearly the abnormality extends much further, but that's not necessary for the diagnosis. Incidentally, in the coronal plane here at the top, you can see a normal muscle here on the patient's left. That's the puborectalis, and then the iliococcygeus slopes upwards like so, this inverted trumpet of the funnel of the pelvic floor. On the other side, there should be muscle here, and there's absolutely nothing. I can't see anything all the way up into the iliococcygeus, which again confirms that this is a full right-sided avulsion. Next, I'll demonstrate tomographic imaging of the puborectalis in a patient with a substantial three-compartment prolapse. We start with a standard two fields of acquisition here on the left-hand side, the mid-sagittal plane with the symphysis pubis, the urethra, the bladder, the cervix here, the vagina here, the anorectum here, the anal canal here, and the anorectal angle here in the back with the levator plate here. On the right-hand side, you see a semi-transparent representation of everything that's in the region of interest, which is that box, and the urethra, the vagina, the anorectum. It is as if you looked at the bottom from below. By manipulating this, we can also get to the pubic rami, which are here and there with the symphysis pubis in the middle. Now, the first thing to do here is to let the patient do a pelvic floor contraction in order to hopefully optimize the definition of the muscle, and she's doing it here. You can see, if you watch the A-plane, you can see that the bladder neck and the cervix and the anorectum have been pulled up quite a bit. They've been pulled upwards and forwards. Then we need to readjust by rotating the A-plane anti-clockwise about 40 degrees or so that the plane of minimal dimensions from the back of the symphysis pubis here to the front of the anorectal angle is approximately in the middle of the box. We can then go to TUI in the C-plane. The C-plane needs to be rotated for it to be upright. And the end result of that is a representation as if you saw the patient from below, as if you looked at the patient's bottom from below with her left-hand side, her left levator here, her right levator over there. The symphysis pubis, these are the pubic rami closing in the middle. We're a bit out. This frame should be here. So we can easily shift that. We make the symphysis pubis close here so that in the middle, that we can just about see the pubic rami join. We also would probably ought to rock the picture a little because it's not quite symmetrical. It's a little better here. Interslice interval is 2.5 millimeters. The symphysis pubis is open here, closing there, and closed there. And really the last thing to do is to measure the levator urethra gap, which is obviously highly abnormal throughout those slices. So you measure from the center of the urethra to wherever you can first pick up some muscle. So here and there, and somewhere there, and here. And it's plainly obvious that all those measurements are highly abnormal, the limit of normal in Caucasians being 2.5 centimeters. So we call that a complete bilateral avulsion. Another thing to point out here is that quite often in women with avulsion you'll see abnormal vessels, abnormal veins, and that dark spot here and then curving along the pelvic side wall over here, that's a substantial vein that you can see through most of those slices. It's actually often even more impressive than that. I'm going to demonstrate assessment of a normal anal sphincter, and we start that by acquiring a volume in the sectional planes. That is, we've switched off the rendering, and what we want to see there is really only the main transducer plane, the A plane, which is transverse because we've placed the transducer transversely on the perineum, and then the mid-sagittal reconstructed plane, which is here in the B plane. The C plane, which is an axial view, we haven't really found any use for yet. We then get the patient to do a pelvic floor contraction, and this is what she's doing here. That seems to improve tissue discrimination, and I think this is probably the best frame that we've got. We then switch to the B plane and adjust our location, the location of that slice in such a way that we can clearly pick up the fascial plane, this here, between the levator ani and the external anal sphincter, which is this drop shape here dorsally, and not quite so clear here ventrally. And of course, you never know what's happened here in somebody who's paras. It's just that here in the back, nothing would have changed since birth unless there was a major colorectal intervention, which you'd hopefully know about. We then rotate that the mid-sagittal plane in order to make the internal sphincter, this dark stripe here, more or less horizontal, and that's probably just about right. We can enlarge it a little, and then that particular plane is our reference plane for the tomographic assessment. So we go to TUI in the A plane. Now you've got what I've just shown you, the mid-sagittal here in the top reference plane, and then all the rest is transverse slices through the muscle. The next thing to do is to determine the location of those slices. And you can play with this here like so to optimize appearances. You can see the lowermost slices are way too low. This slice is just about right, maybe not quite. So we'll move just a tad further up. So there's the end of that drop shape here. And looks like the top slice is indeed above the EAS, should be above the EAS. Also, there's sometimes overlap here. And then we need to adjust the interslice interval. It's actually a tad high. We'll go down to 3.1 maybe. So we should be at the level, we should be pretty much above the EAS here, and we should be below the IAS there. You can see that dark ring of the internal sphincter has pretty much disappeared here. In fact, I'd like it a bit further, probably a bit further up, because I'd like to see the internal sphincter a little more clearly here. And the external sphincter is definitely disappearing. So that's the right location now. We can play with the slice thickness, which is VCI, and usually a slice thickness of about 3 or 4 looks pretty good. We then increase our magnification. And we really normally still want to see the perineum, because who knows what might have happened there. You can see that the distance between the EAS and the surface of the transducer here is about 1 centimeter. That seems to be a really good depth in order to maximize tissue discrimination. And you can see that that sphincter is normal. So the IAS, that dark ring, is normal all the way through. It's beautiful. The bright ring of the EAS is also normal. There's some irregularity here and there, which is a fairly common artifact, because these parts of the EAS run parallel to the incident beam, which means they won't be quite so echogenic. Just normally, this area and that area will be more echogenic than this and that. And it's most obvious where the sphincter starts to thin a little. The perineum, incidentally, looks pretty much normal, maybe a tiny scar here. So this is a completely normal sphincter. Next is assessment of the anal sphincter by tomographic transperineal ultrasound in a patient who had a 3C tear repaired about 10 weeks ago in our labor ward. What you see here is the standard sectional planes acquisition, with the main transducer plane, the A plane, showing a transverse orientation. And then over here is the mid-sagittal, and it's not quite in the right place, so we'll shift this a little so that you can see the mid-sagittal plane. That is the rectal ampulla here, the internal sphincter here and barely visible here, and the external sphincter somewhere here, the anus further out. This here is an axial plane which we haven't really used yet. We start by letting the patient do a pelvic floor contraction to see whether that improves imaging at all, and I think this particular frame is probably the best. That is to distal, that's to proximal, so somewhere around here. It also has the advantage that we can also already pick up the fascial plane here. Let's select that plane and try and see whether the fascial plane is any more obvious anywhere else. Well, it seems to be here. And it's a lot more obvious here. So ending probably about here, because that is the longitudinal muscle of the anus. So the sphincter should be here and there, and you can already see that there's an area where there's obviously quite a bit of external sphincter missing. Let's put this on the TUI in the A plane and then adjust accordingly. So we want to see the last bit of the internal sphincter here. It's just about right, and we want this to be above the external, which it isn't quite, because that slice should really be here. So let's go up with the interslice interval to 2.5 millimeters and shift the entire series cranially until such time as the most cranial slice here is at the upper margin, just above the external sphincter, and that looks just about all right to me. And we can see a little bit of internal sphincter here. The first finding to point out is that there's perineal scarring here. Also, higher up, it actually looks as if the perineum is rather well repaired. The second is the internal sphincter, and for that, let's optimize image settings, probably best via VCI. Yeah, that makes it really obvious. Also, I'd now like to turn down the gain a little. Let's go to image settings. Nah, that's way too soft. And maybe a little over here. Yeah, that doesn't help either. Let's leave it there. I think that's clear enough. You can see quite a bit of irregularity in the internal sphincter, and this is the main reason for me showing this volume, because that's suture material. So somebody had an internal sphincter successfully reunited here. You can see that. That's all the suture material all the way through, and you kind of lose it here. Not sure whether that was such a successful approach here. However, on the other hand, the external sphincter doesn't really look normal anywhere in any of those slices. Also, there's also suture material, some bright spots here and there, here as well, for example, or there, or even higher up. There is suture material there, but I think you appreciate that I will still rate this as a residual defect. Not for the internal, except down here, but for the external. We go to generic angle 3-point, and starting here, not there because we kind of accept that this may be a little too high. Measuring the defect angle would be like this. It's a bit harder there. Maybe like so. Maybe to here. You can see that such a short time after a sphincter repair, in particular if there is still suture material around, it's often harder exactly to know where to put your defect angle. One kind of envisages that these appearances will be a little easier to interpret in another 3 or maybe even in 6 months, given that this was a delayed absorbable material. And in terms of rating that sphincter, I'd say that's actually a fairly reasonable repair. Just visually, it's a fairly reasonable repair after a 3C tear, but there is still a substantial residual defect for the EAS in 5 out of 6 slices. For the internal sphincter, I can see a residual defect really only in this slice, because that one doesn't count, and here you might still be accepting of this being reunited effectively. I hope I've given you some idea of what is possible in pelvic floor imaging. I also hope I've shown you how to make the most of it by using post-processing software. The software that you've just seen in use has the potential to markedly increase your capabilities, both in research, which should be obvious, but also in clinical care. And of course, that is very much what we all ultimately focus on. Thank you for your time.